India is a land of youth, a land of energy, vitality, and ambition. However, there's an increase in the prevalence of lifestyle diseases, that is, diabetes and hypertension. Risk factors responsible for these conditions are stress, sedentary lifestyle, obesity, smoking, and excess alcohol consumption. These lifestyle conditions are also affecting their vitality and energy, and in turn leading to one prominently occurring condition of erectile dysfunction. 52% of Indian males aged 40 to 70 years are suffering from ED, leading to decrease in their confidence level. Healthy sexual life helps in maintaining the feeling of youth and overall well-being in sexual disorder like ED. Zydus Fortisa, a division of Zydus Healthcare Limited, presents Men's Sexual Health Portfolio, which comprises of Penegra, Zydalis, You Desire, Sustanon. Penegra is the #1 prescribed brand of sildenafil with half-life of 4 hours, duration of action up to 8 hours. Penegra can be recommended for moderate to severe ED patient, long-standing diabetes patient, as efficacy is independent of age, duration of ED or diabetes. Zydalis is a brand of tadalafil that comes as mouth-dissolving, mint-flavored tablet. Zydalis has longer duration of action up to 36 hours with no dietary restrictions. Recommended for the treatment of younger 40+ mild to moderate ED patients. Provides spontaneity and better patient compliance. Sustanon is a brand of testosterone used in the management of ED with hypogonadism. Sustanon shows considerable increase in duration and maximum level of penile rigidity. Improved libido in hypogonadal men. You Desire is the brand of Udenafil, which gives assurance of efficacy and safety. Help your ED patients to feel youthful and maintain overall well-being with the benefits of Penegra, Zydalis, Sustanon, and You Desire.
Hello. Very good evening to one and all. I am Somarlo Chatterjee from the marketing team of Zydus Healthcare. And it's an absolute pleasure of mine to welcome you all for today's webinar in sexual dysfunction, on history taking and examination in sexual dysfunction. And what better than today? It's International Women's Day, as you all know. So happy Women's Day to all the beautiful and strong ladies out there. The speaker for today's session is a renowned personality not only in India, but internationally. Dr. Anita Sham, who is a psychiatrist along with a sexologist practice. And along with her, we have none other than the dynamic and charismatic Dr. Deepak Jumani as our very own moderator. But we have a sad news today, not so good news that I also have to share with you. That is one of our speakers for today, Dr. Varsha, who was supposed to speak today. She unfortunately met with an accident. And so let's all of us pray for a speedy recovery. With this note, on this note, handing over the session to our Dr. Jumani sir. Sir, over to you.
Thank you, Somalia. I welcome one and all to this very, very important CME today, especially focusing on the basic thing what we all need to learn in detail. And this is what is going to give us our management, how do we manage and how do we treat. So what's more important than taking a detailed history and what should we ask? And there have been a lot of dilemmas as to how do we talk to women about their sexual dysfunctions, particularly in India. And to enlighten us on all this, we have a very our own Dr. Anita Sham. She is an Indian, born Indian. She's done her MD in psychiatry from Grant Medical College, from my same alma mater. Then she migrated to United States, and now she's in Boston. She had a very key sexual dysfunction, especially men and women both. Today, we are celebrating International Women's Day. In fact, when we started this CME, we wanted to have history taking an examination of both male and female at one go. But unfortunately, Varsha is not here. She's met with a very bad injury. So she's excused herself. So we're focusing only on female sexual dysfunctions, and for which we have Anita Sham, who's going to enlighten us as to what are the key points which we need to understand in history taking, especially in women who are inhibited, who do not want to talk about it, accept whatever is happening in their life. And what are the key things which we should know and examine them to come to a concrete diagnosis. We are not going to talk about investigations or anything. We're just focusing on history taking and examination, which is the key in treating every sexual dysfunctions today. And come Dr. Anita, who's looking and examination sexual dysfunctions.
Good morning, everybody. Thank you, Dr. Jumani, for this opportunity. Am I audible?
Yes, ma'am, you're audible.
Okay. Thank you so much. And I'm going to share my screen right now. So again, thank you, Dr. Jumani, for this opportunity. I'm grateful to Zydus. I'm grateful to my teachers, my family, for all their support and for whatever I am today. So my topic today is history taking an examination in female sexual dysfunction. A very important topic, not much spoken about, but a detailed history can help you reach a diagnosis, and sometimes a good history taken can solve a lot of problems because it can reach directly to the diagnosis and help you in the treatment modality. So today's topic is a very important topic, and I'm glad Dr. Jumani chose this topic. So my name is Anita Sham. I'm a psychiatrist, I'm a clinical sexologist, and I'm a sex coach. I graduated in 2002, and since then have been practicing in the field. So I come with an 18 years of experience in the field and still learning, still getting a lot of training from my teachers and my gurus. These are my disclaimers, and all the information which is shared today are from reputed scientific journals. All the references are at the end of my presentation. My presentation is not strictly restricted to any form of ICD-10, DSM-4, or ICM. It compromises of all these evaluation tools and also my clinical experience. So the goal, of course, I just mentioned, we are going to discuss about history taking and examination and assessment of female sexual dysfunction.
Ma'am, sorry to interrupt, ma'am. Can you please make it full screen? Actually, it's coming. Yeah.
Okay. Now, how do I make it full screen?
The last one, the cup sign.
Okay.
Cup sign.
Yes.
Yeah, ma'am. Perfect.
So,
thank you.
Before we really dig into what is female sexual dysfunction, let's get a little bit more information of what is sexual functioning. Now, sexual functioning is not just targeted to our sexual organs, but it is a complex biopsychosocial process which is coordinated by the neurological, vascular, and endocrinal system. So in general, we need a mind and body to work together to be properly sexually functioning. And that is why we need to focus mainly on the biological, social, and the psychological model. Now, sexual functioning is very difficult and challenging, which is experienced by an individual or couple. And at any stage of a normal sexual functioning, which includes physical pleasure, sexual desire, arousal, and orgasm, any of these interruption can lead to sexual dysfunctioning. The various phases of sexual functioning is the first phase, which is desire, then is arousal, orgasm, and resolution. Now, sexual response cycle refers to the sequence of various physical and emotional changes which happens when somebody is stimulated or there is a sexual trigger. So this is called the non-binary sexual cycle. And as you see, a woman is in a sexual neutral state when exposed to a stimuli and exposed to a trigger which causes arousal. There are these two phases kind of reinforce each other. Like if there is, especially in case of women, we have seen that a trigger or a trigger which causes arousal can lead to desire, and desire can reach to arousal. So these kind of interplay with each other. So very commonly, if there is a client who comes to you and maybe the partner or she says, I lack the desire, I have low desire to be involved in a sexual activity. So one has to remember this aspect of a sexual cycle in women, which is the receptive desire, which is by a trigger or an arousal state. And once this circle is completed and the woman is aroused to involve in a sexual behavior, then starts the orgasm and the resolution phase. And depending on these parameters, depending on these phases, a person is then willing next time to involve in a sexual behavior. So this is another chart which is very helpful to understand if somebody wants to dig into more about the sexual response cycle. We have the International Consultation in Sexual Medicine classification of female sexual behavior. We have also the DSM-5, where the female sexual dysfunction is classified into sexual disorders, which is combined now with female sexual interest arousal disorders. We have the orgasmic disorder, which is the dyspareunia, and also it is clubbed into the genitopelvic penetration disorders and the pain disorders. And there are some, with recent changes or revised DSM-5, there were certain things removed from the classification, which is a sexual aversion disorder was removed and the sexual dysfunction due to general medical condition. So today we are only going to focus on the desire, arousal, orgasm, and the resolution disorders of the female sexual dysfunction. Now, DSM-5 has been very considerate to us. We have various specifiers, and these specifiers will actually help us to understand and to reach to a diagnosis if this is an organic condition or this is a psychological condition. So the various specifiers to keep in mind are, is this condition lifelong? That means, is this individual never had a proper sexual functioning, or it could be acquired, that is with normal sexual functioning, this is suddenly arised. So these specifiers are very important and should definitely be asked during your history taking, is if this is lifelong condition, this is an acquired condition. And of course, this aspect, which is it generalized or is it situational? Does this situation, does this dysfunction or does this challenge arise all the time in every situation, or in all the partners this person is interacting or having sexual contact with, or is she very situational? Is this only with in a certain situation, or is this with a certain partner? And this differentiation, these specifiers will help you if this condition is an organic condition or psychological condition. And if you get a chance, please do review these differentiations, that how you can differentiate between an organic and a psychological condition in a female sexual dysfunction. So also to remember, it's not necessarily that if somebody is coming to you with one problem, there could be one or more conditions which exist in an individual at one point of time. So if an individual comes to you with low desire, that could be associated with arousal issues, that could be associated with the pelvic pain conditions, or it could be associated with orgasmic condition, or it could be something totally outside this box, which is maybe a medical condition, which is maybe a social condition or relationship condition. So there could be one or more conditions involved when a client comes to you. So just keep that in mind, friend. So when we are talking about female sexual dysfunction examination and history taking, we should definitely focus on our evaluation, or our history taking should be very target based, because already when a client is come to you, she or her partner may not be comfortable discussing about intimacy issues, about sexual issues. So we have to be very considerate, we have to be very careful when we talk about sexual problems or sexual challenges in a person. So our target should be whether this person lacks in desire, or the person has decreased desire. If we're talking about arousal, if this person has a question should be targeted towards arousal issues. If you think has orgasmic issues, so our questionnaire should be very target based. And if a person comes to you with some pelvic pain, so our questionnaire should be really targeted towards pelvic pain, keeping in mind all the phases of the sexual response cycle. Now, the basic principle of sexual history. When we talk about history taking, friends, we have to remember that we have to take a timeline history. When did this actually begin? What has been the precipitating factor? What has been the maintaining factors? And what keeps this exacerbation of this chronic condition? And a good sexual history will always help you catching these points when you are talking to your clients. This is a beautiful semi-structured interview questionnaire by Lara et al. And if you could take a printout and elaborate on what are your needs in diagnosing your clients. But this question I find very helpful, and it is by Tara et al. 2-page questionnaire, and it actually really makes it very simple for a history taking. Why is when we look at various parameters of why is age, profession, marital status, the relationship this client is involved in, the religious beliefs, and this questionnaire can really help you to really target and streamline your history taking and come to a proper evaluation. So this 2 slides, I'm sure Dr. Jumani would be sharing my slides with you all. So this can be a very important tool. And thanks to Dr. Avasti and Dr. Rao, we have this beautiful questionnaire which is on the 4 phases of sexual response cycle. And this can also be used to find out if this person has desire issues, arousal, orgasmic, or has pelvic genitopelvic area pain disorder. So what basically causes sexual dysfunctioning, friends? And why are we talking today about history taking and evaluation? We need to be aware that it's not just one aspect of history taking which we need to focus on. We need to focus on the biopsychosocial model while we are taking history. So if a client has come to you with a sexual concern, is there a biological factor behind this? That means, does this person have a medical history? Does this person have any hormonal history? If social, we have to dig into the social aspect of this individual. And we also have to focus into what's going on in the psychic of this client. Is this client happy in the relationship? Is she, if this person has depression, if this person has anxiety, in what circumstances this person has involved in this relationship? And certainly, I'm not going to specify, or I'm not emphasizing on the fact that a woman cannot individually come to a specialist for sexual concern and she has to be married or she has to be in a relationship. I'm completely open to a monogamous relationship or somebody who is in a relationship, married or unmarried. So these factors have to be kept in mind. That's the biological, social, and the psychological aspect. Now, remembering again the same biopsychosocial, biopsychosocial model, we have to create our questionnaire depending on are we tackling the biological aspect, psychological, the socio-cultural aspect. So in my clinical practice, when I deal with when I talk to clients all around the world, this aspect is very important, friends. What has been this individual's upbringing? What has been this individual's thought process about sexuality? Has this person received sex education? What has been the religious belief? What has been the thought process of the masturbatory process or masturbation thought process taught to this client? How is this client influenced by the media? What are this client's expectations? What is this client reading? And that is all these the social cultural aspect, social interpersonal aspect. Is there an history of abuse, or is there an abuse in this relationship, or is this client in a relationship which is abusive, maybe emotional abuse, physical abuse? And how is this relationship with this client? How is the family social support network? Is this client's partners supportive? Is she been accompanied by a partner? And also we have to remember about the professional stressors or the professional demand this person goes through. So these are various models. This is a very nice model, and if we revolve our history taking around this biopsychosocial model, you'll get a very good and a very strong history. Now, we've already discussed this, the psychological aspect, but depression is a two-edged sword, where depression can lead to sexual dysfunctioning, and sexual dysfunction can lead to depression in a relationship or an individual. And we just talked about the social-cultural aspect, that the limited social relationship, even financial stresses. My God, COVID has brought us an ocean of conditions, especially sexual and relationship condition, the financial constraint, the financial situation people are going through, employment situation people are going through. We talked about religious belief, educational background, and of course, sedentary lifestyle. Now, these are the various triggering factors. As I mentioned, when you take a history of a person, especially a sexual history, we have to keep in mind what has led to this situation. What are the predisposing factors? And I just discussed, is this the restrictive upbringing? Is there been a disturbed family relationship? Is there been a trauma? Lack of sexual information? What about what maintains this issue? Why is this issue not getting resolved? Is it the anxiety? Is it the guilt? Is it the shame? Is it the body image? Is it something to do with the sexual behavior which they are having? Or is it the lack of poor emotional intimacy? Is there depression? And something which precipitates these behaviors is there an unexpected expectation? You must certainly bring this aspect in your history taking, that what are the expectation and what are the values of this person who has come to you with a sexual concern, or what are the expectations and beliefs of this couple who has come to you in this relationship? What are their expectations? Is there a discord in the relationship? Is there infidelity? Is there organic disease, or is this person pregnant on oral contraceptive? And depression and anxiety is also always mentioned. So when you are talking to a female, friends, when you talk to a female client, be aware of the various demands and the various roles which a woman plays, and that can affect her sexual functioning. So you always have to remember that what role is she playing right now, and along with being a sister, a mother, or a housewife, or a professional, these demands can be very stressful and can affect sexual behavior of this person. When you take history, you have to pay attention to the clues, that is the timetable of their life. So if this client is accompanied by a partner, we have to keep in mind, we have to ask about how do they spend their time? Do they even get time to spend with each other? And is that one of the main reasons why this client is having sexual dysfunction or sexual challenges? What are the work style of this client? Is both at work and at home? What are the constraints? Most of the time in Indian families, the in-laws are living with the couple, and is that one of the reasons which could be the lead for leading to this problem? How much time they really have in this relationship? How much time do they spend socially, and they have personal time? To also ease this factor, we should talk about the sexual fantasies, the sexual communication, and the masturbation. What are their thoughts about masturbation? Are they comfortable talking about masturbation to each other, talking about body image, genital views? What do they perceive about their genital? Because a lot of times women come to me with their partners that they are not comfortable having oral sex, and of course we need to know what are their beliefs and their values about their own genitals. How do they feel about their genital? Important thing should be talking about their contraception. This is, I just talked to you about what are the predisposing, precipitating, and maintaining factors. To keep in mind also is what are the triggers and what turns on somebody and what turns off. You'll be very surprised that after you take the entire history, and you'll be like, I don't really come to a conclusion. What could that be? Those could be those simple things what can put somebody off in a sexual behavior or a sexual activity. And I have come across, and it could be very hilarious to you all, that a simple thing like maybe the body odor, even a body odor of somebody could actually turn somebody off from having sex. So you have to keep in mind these small little things which could be trivial but are very important in you as a physician to you. And thanks to Dr. Avasti here, we have this beautiful flow chart which helps you to evaluate if this condition is an organic condition or if this is a psychological condition. So you, in your free time, you should definitely look at this beautiful flow chart by Dr. Avasti. Now, most of the time, when a female comes to you, or female comes to a healthcare practitioner, they're not comfortable even talking about sex or taking sex history because it's not their forte. It is not what is comfortable to them. It's not what they've been trained, or sometimes it's lack of education themselves. So thanks to various evaluation modules, we have the allow model, we have the Plicit model, and the MEEBS model. Now, these models, they work individually, and they kind of guide you and navigate you to reach to a proper evaluation. These are basically, again, on the biopsychosocial model, basically dealing with how there is a connection between the mind and body in a sexual relationship. So these are very nice models, and I have used it multiple times. In overall, you must remember the goal of your history taking or your evaluation is that you create a sex positivity in this couple or in this individual. You create an open-mindedness, and you create a pleasure-based approach. And I always believe that it's not you who leads your history taking. It's not you who leads your evaluation. It should be completely client-centered, and they should help you navigate through what's going on in their life and help you to reach a diagnosis. This is a psychosocial evaluation where you look into the various intrapersonal and the interpersonal issues in a client, and also the social aspect. And we kind of just discussed this, but let's quickly go through this. When a couple is in your clinic, you need to know what are their needs and expectation as a couple. And as I always believe, one should not be judgmental of what individual needs and expectations are, because we are not here to judge, we are here to guide and to help them. We also have to look and have a detailed consideration of the individual's cultural, social, ethnic, and religious perspectives. Very important thing, friends, to be aware is the partner involved in the therapy? Is the partner involved in helping you reach a diagnosis of what's really going on with this individual? You have to also look into, oh, sorry about this. You have to also look into the psychological and the mental status of the person who has come to you. And I'm sure we all are well trained in medical school about discussing or coming to a diagnosis about if this person has anxiety, depression, low self-esteem. We just talked about body image, perception of the genital, perception of the body, perception about their own sexual values. Also to remember is the history of sexual trauma. We talked about occupation, social stresses, and we also talked about the socioeconomical status and which can these can affect their sexual functioning. Many medical problems or a detailed medical history will help you to diagnose if this person has an organic condition. So a lot of medicines or a lot of pharmacological therapies are known to cause sexual dysfunctioning. We have the diuretic, the sympatholytics, we have antidepressants, benzodiazepines. So a detailed history of what treatment is this patient currently on. Does this person has any medical conditions which the treatment can affect their sexual functioning? We certainly forget to ask about if they are taking some medication over the counter. If this person is regularly involved in taking cough syrups, if this person is regularly involved in taking painkillers. So a detailed history of what are the over-the-counter medication, and if, oh my God, culturally sanctioned aphrodisiacs. We recently had a case discussion, how we forget to ask what is the culturally sanctioned aphrodisiacs, and that affects the sexual functioning. So those are very important things about medical history. And I just talked to you about the various medical condition that can affect the sexual functioning of an individual. We also have indirect causes, like if this person is anemic, is she in chronic pain, chronic fatigue, chronic malaise? That could affect her sexual functioning. So we have to also be aware of what can be the causes which don't come to you directly. But there could be this underlying reasons why this person is complaining of sexual dysfunctioning. Substance abuse, alcohol intake, alcohol addiction, recreational drug, very commonly now, since even United States, a lot of states in America, they have legalized marijuana use, and we have been seeing increased sexual dysfunctioning. I'm not talking about medicinal use of marijuana, but I'm talking about the increased recreational use. So a good medical history is very important in sexual dysfunction. Now, if a person or a physician is not comfortable taking sexual history, so most of the time it is underdetected, and it also, if it's not detected, it's undertreated, and that could be the main route for a lot of other medical conditions. So if there is a barrier in detection and diagnosis of sexual dysfunctioning, which is related to the healthcare beliefs or attitudes or lack of training, we have various beautiful screeners here. We have the decreased sexual desire screeners, which is a very nice diagnostic questionnaire. We have this wonderful female sexual functional index, which can also help you to see and evaluate the sexual functioning of this individual. You have the female sexual distress scale, which is the revised version. And these can be given to the clients, printouts. They can take their prints out, they can fill it up, and they can come and give it to you. And you have there right in front of you a printed version of your evaluation. And you don't have to really ask those more personal questions if you are not comfortable. Another nice scale which I really like is the satisfaction scale. Because again, as I said, sex satisfaction is very subjective. and it is very subjective in individuals. So a sexual satisfaction scale would really help if you want to really judge if this person is really satisfied in their sexual relationship. So this can be as far as, and once we talk about satisfaction, that is our end goal of why we are evaluating this person, why we want to treat this person's sexual functioning. I just said sexual desire is a very subjective psychological status. And I have seen a lot of my colleagues and my juniors who treat libido as a very biological mechanism, and that is one reason why there is overuse of medications. So when we take a history, friends, we have to remember that the libido is not just the biological mechanism. It is a lot to do with their values and their religious belief, their upbringings. That is the erotic script, how well an individual or a couple communicate with each other in terms of sexuality. Are they comfortable talking about their needs, their expectations, their likings and their dislikes? And we also want to bring in our history taking the motivation. Are these couple really motivated? Is this individual really motivated to bring a change in their sexual functioning? So when we, and I hope after, I'm a strong believer of the 3 different elements of libido, and I strongly talk to my colleagues and my juniors that please do not stigmatize libido to be a biological phenomena. There's a lot which goes with libido, and even with a different hormonal profile, one can change the desire by really focusing on the erotic script and motivation. So we kind of touched on this, the response desire, where trigger can lead to a sexual arousal, which can lead to desire. So we just talked about this. And while we talk about responsive desire, we have to also understand what an adaptive desire response is. Is an adaptive response desire can be positive or can be negative. And let me explain to you, because when we talk about history taking, and if a client is with you for a sexual dysfunction, you want to know, is this response, or is this sexual challenge an adaptive response? So we recently had a client where we worked a lot on the various therapy aspect, on various sex therapy, on various individual therapy, behavioral therapy. We completely forgot about the adaptive response. This was a response to a simple thing that she did not like when her husband was drunk and was sexually involved with her, or they were involved in sex. And that was an adaptive response. So the days when he was not drunk, they were fine, they enjoyed sex. But the days when he consumed alcohol, maybe his breath didn't smell well. So we had missed that part. So along with the response and the responsive desire, we have to know the adaptive response of a woman's sexual behavior. Now, I want to quickly go through what are the various sexual dysfunctions. And when you take an history and when you evaluate these classifications should help you to navigate and understand, okay, what part of sexual dysfunction this client is having, and how can I help this client? So we have, as I told you, the DSM-4, the DSM-5 has clubbed together the interest and arousal desire. So we have the female sexual interest and arousal disorder, which is clubbed together. And this is basically decreased interest, decrease a lack of responsive desire motivation, we also have lack of fantasy, sexual fantasy. All these symptoms come under the female sexual interest and arousal response. So there's no desire to have sex, or there's no interest to have sex. There is no responsive behavior when even aroused. There is no fantasies, there is no genital response. So that will come under the female sexual interest or arousal disorder. And just wanted to make a small note on what is a persistent genital arousal response. So this is also a condition and always probably missed, because it's not heard of or people are not aware, but there is a condition which is called the persistent genital arousal disorder, where there is a constant constant sensation in the genitals of a female, and it is very disturbing, and it is it kind of can be very unpleasant. So if there are two extremes here, we have completely lack of interest, lack of response, and there is a persistent response. So these both should be kept in mind when we talk about the female sexual interest and arousal disorders. And something very important, and very important as a clinician to know, that if sexual desire is a very subjective response, and we have to keep in mind about sexual discrepancy, the desire discrepancies. So I'm sure Dr. Jumani would agree with me that many a times we have clients come to our clinic where somebody says, somebody would complain that maybe my wife has low sex desire, and the wife would complain that maybe he has more sex desire and I'm done with this. So since it's a very subjective response, we have to train, or we have to educate our clients about what is discrepancies. Like, as we all are very different people, each is an individual who feels hungry at different times, we feel thirsty at different times, we do things differently, and same is sex. Each one's desire is very different, and it has to be clearly and very confidently expressed to the client who comes to you, that your needs and your expectation has to be very valid, that your wife cannot have the same desire level the way you have. And we talked about this, which is the hypoactive sexual desire disorder, which is lack of desire response in sexual behavior during sex. And here, the Society of Women's Health Research estimates that 1 in 10 women have hypoactive sexual desire disorder. And also to remember, friends, that the women libido, the women desire changes from time to time, and we are all aware of the various hormonal changes which happens in a woman's life, and especially the monthly cycle, the age-related cycle. And it could also be related to the medication side effects and the stress or the various commitment in their lives. I want to bring to your notice the psychophysiological model, which is the dual control model of sexual behavior in a woman, which is the excitatory and inhibitory response. So when a client comes to you with decreased sexual desire, or even any form of sexual dysfunction, whether it be an arousal, be orgasmic, or even desire, we have to understand that there is one model which is called the dual control. Is this client sufficiently aroused? That means, is this client having insufficient excitatory process? Is she not aroused when her partner wants to have sex with her? Or there is increase in the inhibition, and I just told you about the adaptive behavior. Is certain behaviors inhibiting her sexual desire? And these, if today you can really take back some note, is understanding on this psychophysiological model. If you taking when you take history, if you keep in mind the two dual control process, which is the excitatory response or the inhibitory response, you might not even sometime need any intervention. If just tackling on this aspect, like, hey, maybe she needs more foreplay, or maybe she needs more of sexual communication, or she needs to be more aroused before you have sex, or if something is inhibiting her, then you need to tackle that aspect. So I just wanted to bring that model to you. Now, we talked about the 3 domains and factors which influence the sexual excitation and inhibition response. We talked about the relationship, the behavior, and the medical or the physical condition. We also talked about what are the various etiology which can lead to low sexual desire, and which should also be brought out in your history taking. Now, we tend to forget one thing, friends. If this client has a partner, is this partner regularly available to have sex? Or if the person or if the client works in another country, not available for 6 months, is that the reason why there is low sex desire? Or is this or even sometimes demises, if the client has lost her partner, that could be also the reason that he or she has low sex desire. To bring to also our notice is menopause, which brings a lot of hormonal changes, decreased estrogen, causes a lot of anatomical changes in a person, and also affects the psyche of the client, that can lead to low sex desire. Not to forget the thyroid conditions, hypothyroidism, urinary incontinence. 90% of women after childbearing have incontinence, and because of the shame, because of the incontinence, can lead to low sexual desire. Of course, we should not forget stress, the number one reason for low sex desire. We talked about the hormonal influences which affect a woman in the various stage of her life. During the menses, during the menopause, that can lead to the various sexual dysfunctioning, premenopausal condition. Estrogen deficiency can also, especially during the menopause, can lead to a decrease in the sexual functioning. Please be aware of pregnancy, breastfeeding time. Those are a lot of hormonal imbalance in a person that can lead to decrease or affect their sexual functioning. Just wanted to bring to your notice that there have been research, not concrete, but still in controversy, that oral contraception can affect the sexual functioning of the women, especially decrease interest in the sexual activity and decrease arousal. So when you take a history, it is important to bring to also take an history of if your client is on oral contraception. And of course, with gathering history, I always say, please connect the dots. You should be able to make a flow chart for yourself to understand what is going on in this person's sexual life, and which can help you to make a proper treatment plan. Now, when we are talking to a female as physician, we need to be aware of where are we taking this history, and where is this assessment and examination happening? Because while we talk about sexual behavior, which is such an important and a private part of an individual, your your history taking should be done in a very comfortable, private, confidential way. One cannot be judgmental. One has to be empathic and understanding towards the approach, especially even the language. So if we find a physician who has never taken a sexual history before, is not trained, or is not comfortable because of values, when there is a language, a different language which is used, a not comforting language, trust me, the client is not going to open to talk about their sexual behaviors. Please do not have assumptions. We know that looks can be very deceptive. So let's not reach into any assumption while we are doing a history taking and evaluation of a client. So let's have open-ended questions, put up a proper history taking questionnaire which makes this person more comfortable. No judgments, no assumptions. And we should have a very we should be very careful, have very careful consideration to the cultural and religious factors which can influence sexual behaviors. So these are the various considerations for sexual dysfunctioning. Now, when we talk about evaluating of female sexual dysfunction, how do you evaluate? As I told you, we need to have a clear understanding of regular sexual functioning and with the various sexual dysfunctions. And I just discussed about you, what are the precipitating, what are the predisposing, what are the maintaining factors, and what are the triggering factors. We talked about all this. So this is going to be very helpful for your evaluation. We also have to, we talked about history taking, focused physical examination. We'll talk about the physical examination in a bit, and the lab testing required for evaluation. But please be aware of the comorbid conditions. We talked about the biological factors which can lead to sexual dysfunctioning or affect their sexual dysfunctioning, various medical conditions, cardiovascular condition, thyroid, diabetes, and not to forget the depression and anxiety. Okay. And okay, I think this is about female genital examination. We talked about being private, confidential, making your patient comfortable while talking about sex and sexual examination. And this will, we still have to discuss about the female genital examination. That is only when it is needed. But a good history taking should be able to take care of this. We would definitely need to examine the female genitals if we are suspecting any trauma. And sometimes women do not come and discuss about the abuse and the trauma they are going through. So an examination of the pelvic area would definitely help. Diagnosing with the sexually transmitted diseases will help in physical examination. Okay, we talked about these psychosocial variables, and I think we talked in detail about the lifestyle factor, the psychiatric factor, the sexual history, interpersonal and intrapersonal condition which can lead to sexual dysfunctioning, relationship with their partner. This is we certainly touched on the relationship they are having, the relationship in their relationship with the partner. Are they in harmony with each other? Do they communicate with each other? And sometimes we also forget, my friends, that when we talk about relationship with their partner, how often do they communicate about their sexual needs and their sexual desires? Because all of a sudden, if there is a client or there is a partner who expects sex, but in the whole day or the whole week, they've not talked to each other, not talked about their needs and expectations or their wants. Certainly, there are going to be challenges being involved sexually with that person. Stressors, we should not only the past stressors, even the recent stressors. Like we all know, COVID has been such a big stressor in everybody's life and has led to a lot of turmoils. So what are the life stressors and expectation? We just talked about these. What are their needs? What are their expectations? Is sex their priority, and what do they want to get out of this intervention and this treatment? We talked about the relational factors. We talked about the cultural factors. And to diagnose and evaluate, we also, I just mentioned to you certain questionnaires, but these are also very nice questionnaires which can be used. Take a printout, give it to your clients. It will be filled in timely manner, and you will have a good evaluation of what's happening in their sexual functioning. Now, we talked about the arousal, we talked about the interest, and here comes is orgasmic disorders. So orgasmic disorders are persistent or recurrent delay in or absence of or decrease in the intensity of the orgasmic sensation after a normal sexual excitement phase. So we have to keep in mind that even if the client was well aroused, even the client had desire, if the client complains of any of these things, that is the lack or decrease in orgasmic sensation, then the client has female orgasmic disorder. And a clear, a clear understanding of the various phases of sexual response cycle will help you to pinpoint and diagnose of what part of sexual behavior challenges, sexual functioning challenges is this client having. And when we talk about orgasmic disorder, we have to keep in mind about the various genitopelvic pain, which can lead to orgasmic dysfunction. So while this person has desire, has arousal, she has vaginismus. Vaginismus, also called as closed vagina or locked vagina, when there is a recurrent or persistent involuntary spasm of the musculature of the outer third of vagina. So that is a condition which is very common, mainly psychological, and can be treated very well. But as a physician, you need to be aware of this condition, which can lead to another, again, the cycle of if if a client constantly suffers pain while intercourse, okay, she's not going to have desire to have sex. If she doesn't have desire, she's not going to be aroused because she's constantly thinking about the pain which she's going to go through while every sexual act she's going to have. So female orgasmic disorder is a very important aspect in female sexual functioning. Dyspareunia, again, this is while a clear distinction is very difficult to be made unless and until the clinician is very skilled in taking history. So that's why DSM-4 has put these conditions together as a genitopelvic pain disorder. So kind of saves you from knowing if the person has vaginismus or dyspareunia. But two different conditions, spasm of the outer third of the vagina. Dyspareunia is persistent or recurrent genital pain associated with intercourse. Two different conditions, but yes, they have put it under a same umbrella called as the genitopelvic pain disorders. Various characteristics to be aware of and to keep in mind while taking history is if there is an hypertonic pelvic floor muscle, is she spasmic? Is she very controlled while examination in her lower genital areas? Complain of constant pain. There is apprehension and anxiety. There is the fear of penetration, phobia and avoidance of penetration, and involuntary contact. We just talked about the hypertonicity of the pelvic floor muscle. These characteristics again direct you to genitopelvic pain disorder. Now, the genitopelvic pain disorder is a common concern in women of reproductive age. Despite evidence suggests as much as 40% of women between the age of 20 and 40 years do not seek help for this condition, mainly because they are not aware that this is a condition which is affecting their sexual functioning, or they are ashamed to come out and discuss about this aspect of their sexual functioning. So just to tell you that this is an umbrella term, genitopelvic pain area, genitopelvic pain condition, which consists of dyspareunia, sexual pain, pelvic pain, vaginismus, vulvodynia, vestibulitis, all under the same umbrella, genitopelvic pain disorders. And we just talked about this, which are the 4 dimensions: difficulty having intercourse, constant pain in the genitopelvic area, fear of penetration, and severe control of the pelvic musculature. And there are specifiers in this category. If this is a superficial dyspareunia, that is, this can be due to improper arousal or hypoactive sexual desire, desire disorder. There's vulvovaginitis, atrophic vaginitis, and drug and radiotherapy related, which can be treated very well. You know, it's 1 or 2 sittings with your clients, and you should be able to help the client with the superficial dyspareunia. But when it comes to deep dyspareunia, you would definitely need help of our gynecologist friend who are well trained in this area. If this person would be able to diagnose if this person has endometriosis or PID. So this can the pelvic pain conditions can be primary, which is always there, or it is secondary. This can be global, always present, or this can be situational. This can be spasmodic, that means the person is always in a hypertonic state, or it can be non-spasmodic. Just if I'm not sure if how much is the time, but vulvodynia, we have 2 categories of vulvodynia: pain in the vulvular region, which is provoked vulvodynia, and generalized vulvodynia. Provoked, again, is when there is an effort or there is an intention for penetration. This is characterized by localized provoked pain at the vaginal vestibule, or the entire vulva area is in pain. So just to be aware of this condition, and as a clinician, you should know these 2 conditions. And we have, so just besides the biopsychosocial model and the history taking aspect, history taking on the 3 models, we have to remember there are certain things which can lead to sexual dysfunctioning, especially in women. That is, if they have past history of trauma, they have negative attitude towards sex, this is their cultural upbringing, this is their religious upbringing, or if they have relationship issues. Most of the time, it can also be just simple sexual ignorance, childhood traumas, sexual or physical abuse by their partner can lead to any of these pain disorders or desire or arousal disorders. And sexual abuse, not necessarily it has to be a very triggering, it doesn't have to be one of those sexual encounters which are very stressful, but it can also be an attempt at sexual abuse. And abuse is something which is again subjective, and how the person takes abuse. So it can be an attempt at, the abuse can be classified as attempts as sexual abuse involving touch, or even rape or forced intercourse. So sexual trauma should be dealt or asked in these three different categories. I wanted to bring to your notice about another condition which is gaining a lot of popularity and a lot of research has been done, is chronic clitoral pain and clitoridynia. So I know a lot of people, a lot of clinicians do not touch on these topics, but it can be a very painful condition for a female client who suffers from pain in the clitoral region. So be aware that this is a neurological condition and there are treatments available. I just wanted to bring to your notice that these, to be aware of the chronic clitoral pain and clitoridynia. And to assess pain, specifically during sexual functioning, we have a female sexual functioning index, which can help you evaluate the level of pain, the level of discomfort. And it's a very good parameter to assess sexual functioning or the pain functioning in the woman. If you are in a clinical setting and if the patient is there, we can also, a time and tested assessment tool is the cotton swab testing. We can measure the sensory testing method by a vulvar gestiometer and a tampon testing method. So these three methods are very time tested, cheap methods which can be done in a clinical setting, and you can get a clear picture about the pain in a sexual functioning of the person. And we just talked about it, this, that the assessment should be done in a very private, confidential way, non-judgmental way. The healthcare professional should use communication skills that enhance openness, comfort, trust, and confidence in the patient, that she can open to the physician. So the physician should be very, very welcoming. The physician should be very educated in the field, so the person feels more confident in the client, in the physician. There are various physical examinations which can also be done, and these are the list. Of course, I don't do it in my practice. I completely rely on my history taking, my detailed assessments, but these are various methods which can be done in a clinical setting, and our gynecological friends are very well versed with these physical examination. And if you do not get a proper history or evaluation, we can also do a pelvic floor testing by our physical therapy friends. In recent years, environmental factors have played a very important role. As we know that not necessarily this is the same clean air, clean food, which we are consuming. Environmental factors should not be disregarded. I recently came across a client from Punjab, and for a very long time, this client has been visiting every possible doctor, trying to understand why is his or her sexual functioning being affected. And we came to know after a thorough investigation that the high metals in the water was causing problems in the sexual functioning. So environmental factors should also be aware while one is doing history taking, and while someone is doing assessment. If this person is consuming high level of toxin, chemicals, herbicides, pesticides. Also, is this person consuming estrogenic and hormonal destructive chemicals? So very important, friends, to know, besides the occupational hazards, environmental hazards have not been very helpful in sexual functioning of the female, or even the male rather. So a quick understanding, I don't know if I still have time, but let me quickly check, then I can give you a little bit more description of what are the various sex types and what are the motives inside. So Dr. Jumani, how much time do I have? I can't hear you.
5 more minutes, ma'am. 5 more minutes.
5 more minutes. So yes, let me quickly go through something which I'm very fascinated about and I really like to discuss, is to have an understanding of, friends, what are the different types of sex, because I know it's a misconception or a myth that sex can be only intercourse. But as physician, and after today's class, I hope we get to learn that sex can be vaginal sex, that is a penis and vagina intercourse. We have oral sex, anal sex, fingering or hand job is also sex. Dry humping or genital rubbing is also sex, and self pleasure, which is masturbation, is also a type of sex. So when we have clients come to us and they talk about, I'm having sex problems or I'm having sexual problems, one needs to know what type of sex are they talking about, and what are their myths about sex. Do they know about oral sex, or are they only focused on penetrative sex? So a good understanding of what are different types of sex is very important as clinicians who deal with sexual functioning of clients. And a very good article which I recently read, and I really like to put this in my presentations, is what are the motives of this client to have sex? So whether if this is a single person who comes to your clinic, or it is a couple, we have to really look at the motives. So if your questionnaire, if your history taking and evaluation can look into this part, that is the motive of motives to have sex, this can really help you to pinpoint what evaluation or what intervention will help in this individual. So motives why people have sex, especially women. And I recently was educating my couple, client couple, is men and women have sex for various different reasons. For women, it's more commitment, it's more bonding, it's more emotional, whereas men, it's more physical. And well, that's how the two genders are different. But people have sex, or women have sex, for various reasons. The reason can be purely love and commitment. She thinks that, okay, if I have sex with this person or my partner, that means I love him and I'm committed in the relationship. To express self-esteem. Motives can be resources. When you get a chance, just read this, that a resourceful sex motive is to gain resources. I want a job. Or if this person offers me this job, then I can provide sex in return. So sex can be as an expression. Sex can be to express pleasure or to get pleasure, or it can be simple experience. Casual sex, something very commonly tried by people. So while you're doing a history taking, a few questions on motive can also help, whether the person is an individual, married, unmarried, in a relationship. But the motive to have sex can help you if the person has come with a sexual problem. And this is just a simple questionnaire about the various approaches and various motives to have sex. And we talked about the different types of sex. I have the citation here. At the end of your history taking, friends, at the end of your history taking and evaluation, these are the questions which you should ask. Is my history taking powerful enough? Is it solved the purpose? Is it helping me to reach a proper diagnosis and to make a treatment plan? So these questions like, does this person actually have a sexual dysfunction, or is it just a lack of knowledge, or what is going on? Is this a psychogenic or an organic condition? Your history taking will certainly help you with this. If there is one or more conditions involved in this situation, is it just, as we talked about, is it just orgasmic disorder? Is it just arousal disorder? Just interest disorder? Or it is a combination? Is there any comorbid condition, whether it is medical or whether there is a psychological condition? So at the end of your history taking and evaluation, you should be able to get these answers. Is this sexual dysfunctioning a result of the marital relationship, the marital discord? Is this sexual dysfunctioning because of the motive this person has? And so these are the 10 questions you should ask at the end of your history taking and evaluation completed. Now, these are just some recommendations if you don't reach to a proper diagnosis, but these are some certain lab testing which can be done. And lastly, I know this is not the topic which we are discussing today. Once you have a good history, once you have a good evaluation, you have your questionnaires, we have everything designed, and we know the diagnosis. Your treatment should also be multifactorial, and your treatment plan should be multifaceted. Please do not just jump to symptomology. Just let's not jump to pharmacology. There's much more to a treatment when we talk about sexual dysfunctioning. And friends, never to forget the power of referring to a specialist. If for any reason you are not comfortable, you are not specialized in the field of sexuality, or you're not in the field of sexual medicine, please feel free, please feel empowered to refer. I know it's very difficult to refer and to feel that, oh, I cannot tackle this client because of lack of my specialty. But trust me, sex is such an important and such undertreated topic because of lack of our training, lack of our knowledge, or lack of our expertise. So referring to another physician, to a fellow friend, would help not only you, but would help this wonderful individual or a couple who's come to you. Thank you so very much. These are my references. Always, this is my favorite slide. Please talk about the benefits of sex, why it is emotionally important, why it is physically important. And lastly, if ever you want to look into these charts can help you create a good treatment plan. These are just from Tara et al.'s research article, but nevertheless, discuss about the benefits of sex to your clients, encourage them to be sexually active, to be vital till a long age. And it will really help you as an individual, help you as a physician, and empower sexuality in people. So thank you, Dr. Jamani. I thank you for this opportunity, and I hope I've done justice to the topic.
Yes, very well. Thank you very much, Dr. Anita, for that very elaborative discussion and your lecture on how to take a history and how to examine them. There are a lot of questions, but one question which I would always like to ask, I've asked my seniors also. How would you ask an Indian female who's inhibited that does she get orgasm or no? How will you ask her?
बिल्कुल. एंड जब हिंदी की बात आ रही है तो लेट्स टॉक इन हिंदी कि अगर हम पूछेंगे हमारे फीमेल फ्रेंड को कि भाई आपको ऑर्गेजम, हाउ डू यू फील ऑर्गेजम, तो जरूरी पूछा जाएगा आपको सेक्स करने के बाद आपको कैसा लगता है, आपको इसमें मजा आता है, आपको अच्छा लगता है कि आप दोबारा सेक्सुअली इन्वॉल्व हो अपने पार्टनर के साथ. Because it's very important that the female client feels and feels that orgasmic feeling. नहीं तो फिर कहते हैं ना आधे टाइम lot, as you know, the statistics says there's a lot of fake orgasm in women than to actually experienced orgasm.
Okay. And suppose if the husband has less desire and the wife has a better or more desire, how do you try to ask them these two things? How would you
Bilkul.
judge that who's got less and who's got more desire, and that's creating a relationship issues between them?
Wonderful. So, Dr. Jamani, this is a very nice question. I must thank you for this question, because trust me, all the clients which come to me do have this question that, Madam, I have low desire, or somebody has high desire. And it is not uncommon, Dr. Jamani, to have desire discrepancies. So when a client comes to me and a client tells me, like, maybe that my wife has more desire, or my husband has less desire. So how do I tackle this question is, first of all, is psycho-educating them that what exactly is desire. Okay. First of all, talking about them, giving them the background about desire. Then we try to work on something called as sex mapping and sex calendar. So where we try to meet in between with the various desires of these two individuals, and also help them to understand that sex doesn't necessarily have to be an intercourse, or it has to be a vaginal entry sex, but sex can be more about sensuality and sexuality. So I try to tackle this desire question by psychoeducating them, by also bringing them a treatment plan of how each other can be involved in each other's pleasure, not certainly having the intercourse sex, but being a part of the pleasure.
Thank you very much. Is Somalia, any questions in the chat box? Somalia, can you hear me?
Yes, sir, I can hear you. It was
Yeah,
a
if you have
wonderful session by Ita ma'am, really very enlightening, and we really enjoyed a lot. Ma'am, there are 2-3 questions that have come in the portal. Like, is there any difference between a vaginal and a clitoric orgasm in women?
Yes, of course, and that reminds me of a wonderful discussion we had at the Harvard Medical once I was there, and my teacher, or my attendee at that time, we were talking to a couple, and she said that I can reach orgasm only through clitoral stimulation, and he said that's exactly true. So we were talking to this gentleman and trying to psychoeducate them that women have orgasm, or can have multiple orgasm by clitoral stimulation. Women necessarily will not have orgasm only by vaginal entry. Okay. That is how the anatomy works. So women certainly have orgasm to clitoral stimulation, and not many women will have orgasm through vaginal entry.
Thank you, ma'am. There is one more question. What is more prevalent as far as cause of female sexual dysfunction is concerned? This is organic or more of psychogenic? Which is more than in India?
Certainly more of psychogenic, my friend. Certainly more of psychogenic, because there's a lot, like we talked about the various role a woman plays in her life. There's a lot of stressor, there's a lot of pressure, social pressure, cultural pressure. All those things affect the sexual functioning of the women. And whether be India or anywhere in the world, that sexual functioning is affected by the stressors created in her relationship and in a society, that is maybe in-laws, extended families, the pressure created on her as somebody who's in a different role, and also in somebody who's a sexual partner. So it is definitely very psychological. And I must here quote my teacher, Dr. Vatsa, my teacher, late Dr. Vatsa, that treat every sexual condition as psychological first, and then jump to an organic condition. So unless and until you have evaluated thoroughly that this condition is not psychological, then go to then only look into organic cause. But you can certainly work around the psychological part and help an individual.
Thank you so much, ma'am, for the answer. The last question, actually, I think this is posted by some general, the mass population, not by some doctor. The question is, Is there any medicine for female partner in ED? Any medicine for female partner in ED? There's a question posted in the chat box.
So we're talking about erectile dysfunction.
Yeah, means the person is suffering from erectile dysfunction. So why the female partner? What should the female partner do? Means the person is suffering, the male partner is suffering from erectile dysfunction. What should the female partner do in such cases when the male is suffering?
Yes, and I think I missed that part, that sometimes a person or even a female partner can suffer from sexual dysfunctioning because her partner has a sexual dysfunction. So there is definitely an interpersonal or interrelation between two individuals having sexual dysfunction. So what women can do is, and there's a lot of pressure created. So sex is tend to have more male centered than as a couple centered. So once when we create an openness to have sex and enjoy as a sexual pleasure and not be as like, oh, the penis has to be erect, it has to be hard, it has to be penetrated. No, it is not a burden carried by a man that one has to have an erection and one has to penetrate. No, it is to enjoy. So once this anxiety is removed, that you need to enjoy sex, not it is not a that's why we talked about the different types of sex. It is just not the penetrative sex, but there are different aspects to sex, sexual behavior. So once we remove the stress that, hey, your erection has nothing to do with my pleasure or your pleasure, we can still enjoy sex even without your erection. Of course, it is important for a man, because I had a client recently who's like, but madam, it's so important to me. I understand it's important, but what is more important? Is sex more important, pleasure, enjoyment more important, or your erection is more important? So once you create a platform that sex is to be enjoyed, it's a pleasure base. And then after that, you start treating of like, okay, let's work on your erection also. It can be completely psychological, it can be completely organic. But before that, a female partner should help her partner to ease that anxiety about entry, about erection, about penetration.
Thank you. Thank you
And that,
so much.
what can
for the answer.
certainly
Yeah.
help, something can certainly help here is sexual communication.
Communication is the main part. Yeah, ma'am.
And that too is it's sexual communication. Talking about what you feel about sex, what helps you in sex. Because half the time, I'm going to tell you, even when a female talks to a partner saying that, I love having sex with you, not necessarily it's erection sex. And the person's like, so you don't want, you're not having fun with my erection? As she says, I love that too, but I want to have sex with you. That is more than having penetration. And that push removes that stress from the mind. And hey, that helps me.
The right is it, ma'am. Thank you. Thank you so much, ma'am. Deepak sir, for your closing remarks.
Thank you very much. Thank you very much, Dr. Rani. I think beauty history, like how you came to us and examine the way you diagnose and treat every female sexual dysfunction which exists today. And
I think sir is having some network issue. So, ma'am, thank you so much. Deepak sir, thank you so much for taking out your valuable time and enlightening all of us for this very important session on history taking and examination in female sexual dysfunction. Thank you so much, ma'am. Deepak sir aa gaye shayad. Thank you, Deepak sir, for your valuable time. Thank you so much.
Sir, we have somebody asking for my slides, but I will share my presentation with you, sir, and I will really request the panelists, the audience to view the slides and to look at the various references, because those are wonderful research articles.
He